Right. So physical examination, so once again, digital rectal examination. For suspected colonic cancer, we would send a patient for a colonoscopy. The advantage is that we can get the biopsy and the histopathology from one procedure, because doing a colonoscopy you can take a biopsy, and which allows you us to have the histopathology diagnosis quite quickly. And if unfortunately we think that disease is metastatic, at metastatic stage, then we would get CT, chest, abdomen, pelvis, just to look for changes anywhere else in the body, right? Etiology-wise, we still have like 3/4 of sporadic actually forms, so that's a bit of an issue, because when we know risk factors, we can always think of ways of working on them, but 3/4 of them occur, but we don't know really why at the moment, so they're sporadic, and a quarter of patients have risk factors with them. And one of them is like familial history of polyps, or actually a patient history of polyps previously, a genetic predisposition, and some condition FAP you've probably heard about, and you know about. Both are autosomal dominant inherited syndromes. And the one you quite often see is inflammatory bowel disease, and it's interesting to see that basically the risk of developing cancer in those patients, like Crohn's or ulcerative colitis, increases with the duration of the disease. So let's say someone who's had Crohn's or for 10 years, for example, is much more likely to be at risk of developing cancer than someone who's just been diagnosed right now. Once again, nothing's really 100% predictable, but the duration of the disease is a risk factor itself. And we can see that a patient with Crohn's disease is at much higher risk than patients from a general population of developing colorectal cancer, for example. And those are once again common patients who see daily in the wards. Investigation-wise, as I said, we'll go for a colonoscopy, plexi for patients who are already who have major comorbidities. And we also do CEA levels. Usually we do them baseline, pre-surgery, and it's more actually used after a patient has had surgery, so surgical removal of the tumor. We use carcinoma embryonic antigen as a marker, and once again, a rise suggests possible spread of the disease, metastatic or progression. It's not fully reliable, and as I said today, my registrar, sometimes you have a raised CA post-surgery and you have no evidence of disease, but still, you know, that it has been shown to be predictive factors in some situations. It's an indication. It doesn't tell you what to do clinically, and the decision is obviously up to the specialists in that area and up to the patient, but sometimes getting it right is a bit of a guess as well. Staging, it's important to know what stage disease is, and the management will depend upon. And obviously surgery for resectable tumors is baseline. The more we get rid of tumor tissue, the better we can actually treat later on with chemo or radiotherapy. For non-resectable tumors, we sometimes go straight away to reduce the size of the tumor with radiotherapy first, and then, for example, act on it later on. Right, so it's just really, hopefully, a bit of basic things. So if you have any questions, I'm quite happy to answer. And I also thought, like, just a few things, like, you might actually be seeing practically as an F1 is having a patient, for example, you just based in your team, and once again, you have this patient, he's had a CT, and randomly a CT scan does show, like I had a case, for example, I was on a ward, general medical ward, and some days we were on a patient with non-specific symptoms. We've randomly done a CT, not randomly, we've done a CT scan, a head CT as part of management, and this CT has shown quite extensive brain tumor out of the blue. No one's expecting it, no the family, no the patient, no you. And sometimes you just have to, sometimes it will be your turn, you'll be on your own, or there'll be no senior, and you'll just have to, the family is pressuring you to know what's going on, and you have to, sometimes you have to be the one telling the patient what's going on. So, breaking bad news, that's something you really practice, and I think it's part of your good skills. But once again, a few advice. If you don't feel really comfortable if you don't feel that you're the best person, for example, oncology is a very specific area, if you don't think like you're the best placed individual to break this bad news or to tell the patient what's actually going on, you can always choose not to and try to get advice from a senior, or the best thing would be, for example, getting an oncology registrar or someone who would speak to the family and to the patient, explaining that it is above your skills and that you're not just feeling confident enough, comfortable enough. Sometimes you still have to, and in that case, you would always see with agreement, you always try to get a private setting, okay, so get the patient in a comfortable environment of the family. Try to get sometimes a nurse, and most of the time get someone to chaperone you, so it's always good to have a nurse around. Be in a private environment, sit them down, tell them that you are the doctor on this ward, that you are not specialized in that area, but that if they are happy, you're happy to tell them in your words and limited words what's going on. But once again, you won't be able to answer all those questions, because there'll be straight away questions, oh, what's the prognosis, what's the treatment, how long do I have to live? And those are the questions we can answer. So recognize limitations, that's fine. If you feel confident and your seniors agree for you to talk through, you're more than welcome to. But for any questions regarding prognosis or treatment, we can always refer to seniors. But sometimes you will be in situations to do it on your own, and it's not easy, and patients don't, obviously no one expects it, and it's hard for you because in some cases, you know, it happens when you don't expect it. So you can always do it, but try to ensure private settings. They'll break the bad news pretty quickly. Ask for any bad news, you know, give the setting and refer to any specialist advice, and say that you're happy to find out anything you don't know, and that you're quite happy for any oncologist, registrar, for example, anyone to answer any further questions, because those patients will probably be followed up in clinic. Something else you can think of as an F1, basically you just recognize that most of the time diagnosing cancer is quite, you think like now it's not really relevant, but on your day job you just realize that this is an incidental finding most of the time. The patient comes for something else, something for a reason we think might be just benign, or we just don't know why, and suddenly we're faced with the diagnosis and the CT result, and so it's something much more common than we think, and dealing with it is, the other part is basically for patients who are diagnosed at very late stage and metastatic disease, sometimes there is no time to go through all of this, and the patient has very limited time to live. And they, for example, in those cases, it's very good. There's no time to go actually transfer him to oncology, wouldn't do anything. So it is important to discuss with if possible, with the patient, if not with his relatives, what his options are, what his wishes would be. Would it be to have his end of life at home? Because if this is the case, hospitals have in place fast-track planning, fast-track discharge, which can really allow patients to spend their last days, or sometimes hours of their life comfortable in their own environment, if this is what they wish. So those arrangements are in place, and I think we shouldn't be afraid of, talking about that. Sometimes, we just never mention it to our relatives or to anyone of your friends, but things just happen, and at some point you're just not able to say what you actually would have wished. So don't be afraid to ask, because there are systems in place to allow this fast discharge. That's something you will be dealing as well with. Then you obviously have the option of Macmillan nurses and good palliative care system in place, because we all believe that the best environment for a patient is not to have his end of life in the hospital setting, unless this is something that's absolutely necessary and they wish to. So it's a different approach. Oncology has many, many areas and has many cross bridges with actually palliative care, as we probably see. And sometimes it's more of a human aspect than at the general level than actually dealing with healing the disease.